I want to thank the program committee and the society for the opportunity to talk with you today. In the last year and a half, I finally answered the question of what a molecular virologist and structural virologist can do in surgery. I have no disclosures, just years of experience studying the stability of viruses, which is what I'm going to bring to you today to try and answer this question. So let's just review briefly. This is a single-stranded RNA virus that's captured in a nucleocapsid protein, which is stabilized by membrane protein. It encapsulates the virus and forms an envelope. Sticking out of that is the S protein or spike protein, which is a major gnarly thing that we've seen in all the pictograms. This whole thing is 120 nanometers, which is the perfect size for aerosolization. This virus family is responsible for primarily respiratory and enteric infections, and it's been isolated from feces, bile, peritoneal fluid. It is hard to isolate, though. It's an RNA virus, so it can be inherently difficult to find it. The viral loads are higher in GI symptomatic patients, and so I would warn you that we need more research on infectivity, but those patients are at much higher risk. We do know that it's transmitted via aerosolization, which can be accomplished many ways, not just via heat or diathermy, which just remember that when my opponent talks. It's not just smoke that matters. Aerosols can be created by suction, by regenerated from fluid droplets, and also from forceful air expulsion, like around a laparoscopic port. I just want you to imagine those aerosol droplets coming up around the port, headed towards that negative pressure vent in the sky. If you have to operate, please mitigate those risks. Keep in mind that viruses mutate. We've already talked about that already, and I think that landscape is changing underneath our feet, not only in the S protein, but also in that M protein, and considering how long it might be stable in the environment. Ask yourself, do you really have to operate? Know whether or not you can mitigate any of the risks. Is that patient highly infective, and do they have a high viral load?
That was better than the last one. I'll give you that. So, all right. Certainly, you should know your enemy. I don't disagree with that. And in knowing the enemy, there is no evidence that there's viral transmission through plume smoke. There is a lot of suggestion. There are studies through gynecological procedures that the HPV virus goes into the plume and can be transmitted that way. It has been found on the surgeons who performed that, but those were not the virus in those places were not active. They were killed basically by the energy that was used during the procedure. So while it is a theoretical risk, there's been no evidence that it does actually transmit with the plume or surgical smoke. I would also argue that performing it laparoscopically is not a difficult adjustment to make. We've talked about not exchanging your instruments as much, talked about not letting the air rush out from the pneumoperitoneum when you do the procedure. Those are just minor adjustments. They really aren't that hard to do. Letting the pneumoperitoneum out slowly through a filter also is not very difficult. It does take some time. It takes some getting used to. But most laparoscopic machines these days have that technology on them. It's pretty inherent. And even if you don't, hooking the sucker up to a port seems to work pretty well also, as long as there's an OPA filter. If anybody has performed open surgery recently and tried to suction out the smoke, which is supposedly the standard actually, a few years ago, that was what the aortin had suggested. However, in most operating rooms, they don't have that bovie with the suction attached to it, and they don't have an assistant who follows them around everywhere they use the energy device to capture all the smoke. So I remember doing one of these cases, a COVID-positive patient that had to be open for different reasons. And I even told, we had two techs, and I even told one of them, look, you just need to follow me around with this sucker. We have another sucker. And as I was performing my colon surgery, I watched all the plume go around the suction device, and a very small area of the smoke was actually being evacuated that way. I think with laparoscopy, it closes off all of that pneumoperitoneum and air, at least controls it for a while, so that when it comes time to get rid of it, it can be done in a more controlled fashion. And then finally, I think there can be no doubt there's a benefit to the postoperative stay for the patients. There are multiple studies that talk about the difference in length of stay for the procedure, as well as pulmonary complications. And so if we're in an area where we need to get patients in and out of the hospital as fast as possible, spare them any pulmonary complications, then I think laparoscopy is the better option for that. Thank you.
Oh boy, this is where the virology really helps. So just want to tell you guys, there's a big difference between this virus and the ones that we were just talking about. So human papilloma and HPV are two very different viruses. They're DNA-based viruses. They're much larger in size, so they can tolerate heat better, which is why they can be transmitted that way. So in the fulguration of warts, for instance, around in anal condyloma, you can have aerosolation of that virus just from heat. This virus probably is not as susceptible to heat. However, because it is smaller in its size, it is easier to transmit via aerosolization that way. And so it's not heat that is important here. So it's not just the smoke that I want you to focus on, it's all of the fluid droplets that are present in either laparoscopy or laparotomy, but do you have a better chance of controlling them? And are you under positive pressure from the pneumoperitoneum, right? In a negative pressure room, where your face is standing between the positive pressure and the negative pressure vent. Just think about that. The other thing that I want to point out is that many of these studies that talk about, trying to avoid laparoscopy, we do have alternatives. So we've described doing appendectomies under spinal. There was not an increase in length of stay. It doesn't change the outcome for the patient significantly. There are risks associated with an open appendectomy, but it turns out we still remember how to do them, even though it's not as minimally invasive. So I think we have to consider those two options when we talk about what might be best for a COVID-positive patient who probably shouldn't be in the operating room if we can avoid it. Can we minimize the general anesthesia risk that is required with laparoscopy by doing other modes of anesthesia? And lastly, what is the risk to the staff?
What now? Oh. Well, that was just my argumentative style. I do have. All right, so I must admit I did lie to you earlier. I said there was no evidence of any viral transmission, especially of the SARS-CoV-2 virus. But just 2 weeks ago, and I just made this aware that there was a study done on 20 patients who were known COVID positive, and there was transmission. It was more of a controlled study. There was actually the virus was found in one of the suction devices from the study, but they were all open cases.